Hi, and welcome to the Surur Pearls. Today we'll talk about gases. We have four different gases in the air that we breathe: CO2, nitrogen, oxygen, and water vapor. We're going to concentrate on the CO2, nitrogen, and oxygen. There are a lot of applications and important concepts to understand when we think about this in the treatment of critically ill patients. For example, which one is the fastest diffusible across the semipermeable membranes? Is it CO2, nitrogen, or oxygen? Believe it or not, it's actually CO2. CO2 is very fastly diffusible, and that actually is reflected in a lot of things that we do. For example, when we go to the operating room and a surgeon insufflate a gas in laparoscopic surgery to open up the abdomen and make it possible for the surgeon to see and operate using a laparoscope, he doesn't use or she doesn't use air. They use CO2. CO2 because it's easily diffusible. So at the end of the operation, this CO2 can be absorbed easily through the bloodstream and easily gotten rid of by the lungs. In rare instances, CO2 is absorbed too much during the operation, and that sometimes can result in acidosis, usually transient. But if we use air or oxygen, people will be pregnant in the recovery room and will go home with a big belly, disfiguring, and uncomfortable. Where else we apply that? It's applied for the age-long tradition of anesthesia, where anesthesiologists measure end-tidal CO2 during the operations. And if there's an acute reduction of the end-tidal CO2, typically that means that the patient is having a sudden reduction in his cardiac output. That is usually qualitative. That has been also translated into the ER literature and the critical care literature, where now we monitor the efficacy and adequacy of CPR by using the end-tidal CO2. That's because CO2 diffusion across the semipermeable membrane has few factors that affect it. It doesn't have a lot of factors that affect it. So most of the time, more than 90% of the time, it is directly related to the cardiac output, and there's no other factors. So when you have a cardiac arrest, if you have a low end-tidal CO2, that means your CPR is not adequate. Where else that shows up in our practice? So in the equations that we know and use a lot in critical care, like the alveolar equation, one of the most famous equations in critical care. This is the equation where we try to calculate and predict how much alveolar O2 or the partial pressure of alveolar O2. That is P alveolar O2 equal P inspired O2 minus P arterial CO2 divided by the respiratory quotient. The gist of this equation is that the amount of oxygen in the alveoli is equal to the amount of oxygen inspired minus how much CO2 are in the alveoli. But because the amount of CO2 in the alveoli and the amount of CO2 in the blood are directly proportional and close to each other, for ease, we use the P arterial O2 because that's practical. That's what we can get easily in the ICU using a blood gas. So these are the applications of CO2. How about oxygen? Oxygen diffuses a little bit, worse or slower than CO2, but better than nitrogen, for example. And that has some implications. For example, when we ambo bag somebody, people mistakenly think that the ambo bagging is the same. You take the ambo bag and just keep squeezing the ambo bag back and forth, back and forth. No, the ambu bagging for a patient who is hypoventilating or acidotic is different than the ambu bagging of a patient who is hypoxic. Patient who's hypoventilating, the ambu bagging has to be back and forth, back and forth, back and forth. You don't need to leave the air that you're pushing or the gas that you're pushing inside the patient for a long time to exchange the CO2. A small amount of time is enough for the CO2 to exchange from the blood to the gas in the alveoli, and then you get the gas out and put more gas in to remove more CO2. So CO2 is fastly diffusible, that's why you fastly ventilate. As opposed to O2, where if the patient is hypoxic, the way you ambu bag a patient has to be different. The ambu bagging has to be where you push air in and leave it in for a little bit. And that allows the oxygen to exchange through the semipermeable membrane, and then you let go. And you do it again, and you let go, and you do it again. And you stay, and then you let go. That's the difference in ventilation using the ambu bag. Same thing translates when you ventilate somebody. Most of the things that we do to improve oxygenation result in worsening of ventilation. Most of them. For example, to improve oxygenation, you have to increase the inspiratory times on a vent. You have to keep the inspiratory gas in the ventilator for a longer period of time, so you can allow free gas exchange. And allow time for oxygen to exchange. That goes against the way to ventilate with CO2. How about nitrogen? Nitrogen is the worst out of these three gases to be absorbed or to be transferable across the semipermeable membrane. And that has its own application. Nitrogen is actually very useful when we have it in air. Without nitrogen, our alveoli could completely collapse. How? If you imagine if you have 100% oxygen gas inhalation, what's going to happen is that potentially, especially in alveoli that are lower down in the lungs, these alveoli, because of the time that if you spend time in a little bit more time than you would spend to exchange CO2, if you spend the regular time for inspiratory time, the oxygen inside the alveoli could potentially almost completely get absorbed by the circulation, and that results in atelectasis of these alveoli. And once you reach to a certain critical point, the surfactant will invite more atelectasis as opposed to opening the lungs. So there is a very well-known entity called absorption atelectasis, and that is a result of continuous and a prolonged inhalation of 100% oxygen. The presence of nitrogen, usually 80% nitrogen in air, that actually acts as a stent for the alveoli. It keeps the alveoli open because it doesn't get absorbed easily. It needs seconds and seconds and seconds to be absorbed. And typically that doesn't happen in ventilation. So usually the result of that is that we can keep our alveoli, especially the lower parts of the lung, open as long as we have some nitrogen in the inhalation gas. Also, has nothing to do with medicine, but for example, if you, some of the new cars, you fill the tires with nitrogen. We don't fill the tires with oxygen anymore because of air anymore, because we don't want the oxygen part of the air, because that escapes through the crevices and the semi-permeable membranes, and that results in the need to refill the tire more frequently. So filling tires with nitrogen is better. On the other hand, if you have a pneumothorax, if somebody burst his alveoli and developed a pneumothorax, that pneumothorax is full of air that has 80% nitrogen. It's very difficult to get resorbed, especially if you don't put a chest tube. So without putting a chest tube, especially if it's a smaller type pneumothorax, if you put the patient on 100% oxygen, assuming that there still is a hole or a connection between the alveoli and the pneumothorax, that results in filling the pneumothorax. Basically, the oxygen is replacing the nitrogen to some extent in the pneumothorax, and that results in the pneumothorax being easily absorbed and decrease in size. Same thing applies when you have air embolism. People with air embolism, who they get from inappropriate removal of central line or during craniotomies or etc. This air embolism can result in death or strokes, or like any other emboli. So in order to get rid of these emboli as fast as possible, the strategy is to put the patient on in a hyperbaric chamber, which gives you a very, very high PO2 that results in replacement of most of the nitrogen in the air bubbles, and that results in easier absorption of these air bubbles and better outcomes. If you know these characteristics of gases, you will have much easier time understanding how we ventilate and oxygenate our critically ill patients. Thank you, and we'll see you the next time.